Welcome to Access Back Channel, expert conversations about sexual abuse treatment and prevention. Today, we have the pleasure of talking with Dr. Jill Stinson and Rachel Carpenter on community-level contributors to sexual aggression. Dr. Stinson is a licensed clinical psychologist and the director of clinical training in the Department of Psychology at East Tennessee State University. She received her dual doctorate in clinical psychology and psychology, policy, and law from the University of Arizona prior to serving as the sex offender treatment coordinator at Fulton State Hospital with the Missouri Department of Mental Health. Her research focuses on serious mental illness, personality disorder, self-regulatory problems, and histories of early childhood maltreatment in persons who have committed violent and sexual offenses, as well as issues related to community reentry, stigma, and suicidality in justice-involved populations. Dr. Stinson has authored 3 books related to etiology and treatment of sexual offending and motivation to engage in therapy. She serves as an associate editor for sexual abuse and is the secretary of the board of the Council of University Directors of Clinical Psychology. Rachel Carpenter is a PhD candidate in clinical psychology at East Tennessee State University, studying under Dr. Jill Stinson. Her dissertation used hierarchical linear modeling to explore the larger community-level factors associated with intimate partner violence. Prior to completing her doctoral requirements, she obtained her master's degree in psychological science at the University of North Florida with a focus on mental health, working memory, augmented reality, and neuropsychology to better understand mental health. Previously published works have examined suicide and adverse child experience in forensic populations, working memory and testing modalities, augmented reality and mood, and cognitive considerations within child development. Rachel is preparing to attend the University of Mississippi Medical Center Doctoral Psychology Internship Program, and once completed, hopes to focus jointly on research dissemination and clinical activity. So welcome, Dr. Stinson and Rachel. Thank you very much for joining me on this Back Channel podcast. How are you today?
Good, thank you.
Good. How is East Tennessee?
Hot currently.
Okay. Well, it cooled off here in Rhode Island, so it's nice and dry right now. But then it's going to heat up on the weekend. All right, but we're not here to talk about the weather. So let's start. We want to have this conversation with you based on the great article that you published recently in Sexual Abuse about community factors that can contribute to sexual aggression, particularly in intimate partner situations. Can I ask first, how did you become interested in these type of factors leading to sexual aggression in particular?
Yes, well, it's kind of, I don't know if it's a long story, but a lot of things happen to lead up to the point of looking at IPSV, or intimate partner sexual violence. So I was really working with intimate partner violence broadly for my doctoral comps. So at ETSU, we do a prelim, which is basically just a publication. And to start off, I was using a rather large data set, and it was coming from the Tennessee Bureau of Investigation reporting system. And what's cool about this data set, it's just all of the police reports of different forms of IPV, and it's all reported, and then people can use it for research purposes. So I was kind of starting there. And then the more I kind of read about intimate partner violence, it seemed like the field was really starting to look at the larger community and moving away from just focusing on the individual level factors. So there's, other things within the system that contribute to IPV. So I think I kind of basically brought this to Jill, and I was like, I'm kind of interested in it. And Jill knows so much about different data sets. And she was like, you should use the county health rankings and roadmap system, which is kind of another large repository of data that looks at community level factors at the county level. So, oh gosh, there's so many. So there's rate of primary care physicians within a county. There's rate of income inequality within a county. Basically anything you can think of that you'd want to study is within this data set. So that was kind of the merger between the TBI data and county health rankings and roadmaps. And then kind of from there, my data included all types of intimate partner violence, but I became more interested specifically in the sexual violence piece. And a lot of the time, sexual violence falls under the umbrella of IPV, but there is potential for specific risk factors with sexual violence. So we continued to kind of look at intimate partner sexual violence, and we kind of ran into some data problems because there's so few cases of sexual violence. It's one of the most underreported crimes. So you'll see kind of within the paper, we used a case control design, which was really fun because I had never done that before. I didn't even know what it was, but it's really used in epidemiology. Jill had a colleague that came in and helped us with it. And so basically it let us match rare events to the common occurrences to see what really predicted IPSV. So basically started with my comps, a lot of conversations, and here we are.
Cool. So what are some of the community level factors that you found were related to sexual aggression?
So the main ones we really found, so all were at the county level. So again, these factors came from the county health rankings and roadmaps. And so the ones that we found that were significantly associated with intimate partner sexual violence was income inequality. And so this is really just the disparity in the distribution of income between individuals within the entire county. And, you know, this wasn't necessarily super surprising. Socioeconomic factors have long been studied with IPV and IPSV, so much so that some researchers recommend controlling for certain socioeconomic factors because they're so important. So that was one. We also found rate of firearm fatalities. And this is also kind of not super surprising, unfortunately. We know that just having a firearm in the home or owning a firearm increases the likelihood of IPV for certain situations. And then lastly, kind of a curveball we found was percentage of female residents. We were not expecting this. And there really isn't a lot of research explaining this within the United States. Cross-culturally, there's a lot of research looking at this. And they found, and some researchers have found that uneven sex ratios within certain African areas show higher rates of IPV, kind of more violent competition between males, which then of course leads to IPV within females. But definitely more research is needed to really understand this as to why we found this within Tennessee.
I was also very much struck by the percentage of women in the counties. And I had read many years ago about how societies may, the customs, whether things are liberal or conservative, may have or at least gender or sexual norms tend to differ depending on the percentage of the population. So that if there are more women than men, then the sexual norms tend to be more liberal, so that the men can be out there having lots of sex. But if the reverse is true, then it goes very conservative in order to control women. So it's nice to see that we have really evolved very far from like baboons that probably do the same thing. So I wasn't surprised, but I was struck at this particular finding. What do you could you paint a picture then of what is life like with these factors in a community? You know, if somebody is evaluating an individual, what might they be? It might be worth it for them to be looking at.
That's a great question. I think it's important to mention first that these are definitely proxy variables. So, we can't make any, very strong conclusions or generalizations. So, for example, these variables tell us doesn't tell us if the individual owned a firearm or if they're living in an area that has high income inequality. But they give us, like you said, it does paint a picture for us. And so, like I said before, a lot of these factors we found do show higher risk for intimate partner violence. So what I think is particularly interesting is that we have these very well-known individual level factors, such as being younger, engaging in substance use, having a high rate of adverse childhood experiences, all of these things. And so if you have these individual level factors, and now we have more information from the community, say we have someone come in looking for resources, we can ask some of these community level questions, and maybe we can provide them with additional resources. So maybe they do have a firearm in their home. Maybe they're at a place where they want to develop a safety plan for eventually leaving the relationship, or maybe they don't want to leave the relationship, but maybe we're now able to come up with some community level resources that otherwise we didn't necessarily know were risk factors. And also, just from my personal clinical experience, I work up in Mountain City, Tennessee, and it is a very rural, and I see intimate partner violence quite often. And interestingly, I see a lot of these community level factors kind of come into play. So, when you have inadequate financial support, when you're facing a lot of these cultural boundaries, when you're maybe facing reprisal from your partner from leaving, sometimes it becomes really difficult to even know what resources are available at the community level. So again, I think this just helps paint a bigger picture of maybe the people that need the most help for specific targeted resources.
And perhaps if even if the person doesn't have, let's say I live in a place like this. I live in a place where there's lots of firearms death, there's income inequality, there's few women. Even if I don't own a firearm, I would think that my level of stress would be fairly high, given the possibility of being at the other end of the firearm at some point. It also, I'll go back to the male thing, because also this seems that being a man is a huge risk factor, all things being considered, and then you get more stress and forget about it because we're not particularly well versed in coping skills. But for individuals convicted of sex offenses in general, I mean, I would think that these are very worthy questions to investigate in order to assess a little bit more of what their environment was like. I know that as researchers, we go, well, this is the evidence for this particular sample, for this particular issue, but it doesn't hurt to ask some questions in order to contextualize the individual. Are there other community factors that you think would be interesting to assess?
Yes, I wish I had $1 million because I have so many that I want to look at.
Yeah. You and me both. It's like, where are all the grants? And
yes.
People getting grants, and it's like, who do they pray to? Because I don't get anything.
I need a grant god to help me out, but this actually is related to your previous point. There's so many variables. There's an infinite amount of variables that are happening within this community, and we'll most likely not be able to tap into them. But we also know just like high levels of stress living in areas where maybe there's high rates of firearms and poverty, and maybe there's child rearing considerations, and also intergenerational intergenerational trauma transmission. You know, if you have been born into this area and raised in this area, it's possible that maybe you never saw kind of a healthy relationship, and we know that that leads to intimate partner violence within their later adult relationships. So just some really important other things to consider. But I think one of the main things that I would really like to look at is social disorder or social disorganization. And this is kind of from one of the guiding theories that I've looked at within IPV at the community level. It was actually an original theory developed in criminology, but it basically is just looking at how well does the community function together? How much are people helping each other? You know, how much is it like it takes a village per se? And so there's a lot of research looking at this, but I would love to kind of bring that in just to kind of support that theory that I'm using. And then one other thing that I'm really interested in is, you know, Jill and I have worked at the community level a lot. My dissertation looked at a little bit of the society, but I would really like to kind of do a deep dive into the societal level. And, you know, within this paper, we didn't really examine that, but I think this is really important, especially, you know, with our current climate. I would really like to use the Gender Inequality Index formula, and this came from the UN Development Program. And it's used a lot within social psychology. It's also used a lot internationally to try and explain IPV. You know, so these gender disparities, such as within the United States in the pay gap between males and females. But I think this would be interesting to see if this is affecting IPV right now, because, like I said, it's really just been looking at internationally. And then lastly, I'd really just like to start looking at specific interactions with other known individual level factors. So recently, we see that reciprocal partner violence is a lot more common than maybe we once expected. Kind of before, I think we've thought about IPV as you have the perpetrator and the survivor. And just like any psychological phenomenon, things are always a little bit more complicated than we think. So I would like to look at that, and then also some of these individual level variables that I wasn't able to really get from the TBI data. So, you know, previous substance use, previous IPV relationships, and, you know, to see how those interact with community level socioeconomics, as well as some of the other variables that we found here.
Yeah, if I could just jump in for a moment, I think another thing that it would be really interesting to look at the community level, Rachel just gave the example of a town here called Mountain City that's very, very rural and very isolated. And the idea of familial or acquaintance density, and, you know, how interwoven are your supports in that community with the perpetrator of violence against you. You know, looking at the longer someone's in a violent relationship, the more severe the violence they endure, which is one of the things that, you know, was noted within the current paper. But also this idea that, you know, everyone says, why don't they just leave? And it's like, if every single person you know is related to the person who's doing this to you, it makes it extremely difficult to extricate yourself from that situation. And it, you know, to look at the level of supports and how much those supports are dependent on people who may condone the violence, people who may engage in violence themselves, and how much that's affected by the community that you're in and available supports that you have. You know, we talk about people leaving and going to a safe house, but if you live in a town of only a few hundred or a few thousand people, everyone knows where that safe house is and they know you're there, right? So how safe is it really? And then does this then predispose people to stay in violent relationships and expose themselves to a greater degree of harm for lengthier periods of time? I think that's one of those more longitudinal things we'd be interested in looking at. How does this all play out in a community like some of the ones that we studied here in Tennessee?
I agree. And Jill, just kind of to add to that, like, you know, I think it's important to note that the most dangerous time for, you know, a woman is when she leaves the relationship. And I know I've seen up in Mountain City, a lot of the people that I've maybe referred to, they know the people that work at the safe house. And, you know, getting to a different safe house in a surrounding community is extremely difficult, because then we have those financial barriers. So it's just extremely complicated. And I think we need to come up with some maybe novel approaches to getting access for treatment for some of these areas, like you mentioned.
Yeah, it's really striking the stressors. And even in, I remember reading at some point a while back about Sweden, where, supposedly gender, there's much better gender equality, not exactly like perfect gender equality, but better. But the rates of sexual aggression have been increasing, at least in the past few years, if not the last decade, and that has been tied to income inequality. So those, the financial stressors and the way that the person has grown up and all these systemic issues are going to impact these rates of violence. I definitely agree. Any thoughts about looking at intimate partner violence in LGBTQ relationships?
Yes. To go back to your, sorry to jump back, but your recent point about Sweden, I'm fascinated by that. The Nordic paradox. There's 3 countries and their IPV rates are through the roof. And I love how you mentioned that income inequality. I was recently just reading about that as that being the explanation. And it's really true. It really boils down to money for everything. But yes, to go back to your original question, Jill and I are currently working on a paper right now on some revisions, and a large part of it is looking at the LGBTQIA plus population, just trying to figure out, what is kind of happening within this population that maybe we haven't seen before within a large data set. We do seem to see that within this population, there are higher rates of sexual violence and just partner violence in general. So we're hoping to explore this a little bit more. And yeah, Jill, I'm not sure. Is there anything else you want to add with that, with LGBTQ?
Yeah, I mean, one of the things, obviously, we need to understand more at the individual level. I think it's been very challenging for us as we look at that population, because when we're using secondary data, it's not always coded if law enforcement didn't ask what the nature of the relationship was. So there may be a number of instances that are actually IPV, but that are coded as like roommate violence because they didn't ask about whether or not they were in a romantic relationship. So that's challenging. I also think, though, one of the things that would be interesting to look at in terms of community factors, and this is maybe specific to this or other regions, but to look at the role of religion and community supports when you have a person in an LGBTQ relationship that is characterized by violence, because I don't want to broadly speak for the entire state. But Tennessee tends to be pretty heavily Christian, evangelical Christian, and pretty heavily conservative. And LGBTQIA folks are not necessarily treated very well by that particular religious orientation. And so thinking about, how isolated people in those relationships may feel from the larger surrounding community, how isolated they may feel from their families who are very, very religious, and how that affects their ability to seek help in these relationships, whether or not communities that are more or less religious have, more or less isolation for people in LGBTQIA partnerships. And so I think that would be a very interesting community level variable to look at. But again, as I mentioned, and we mentioned this in the paper as well, in the limitations, it was really hard to get these data because people simply didn't ask and they didn't record a lot of relationships, and that was one of our smallest groups. So it's really hard to know very much about what's happening in those partnerships.
Yeah. There's another kind of like weird situation in that applies to intimate partner violence with LGBTQ couples. We had a student in the program where I am a master's student who was interested in assessing police officers' take on calls where the people involved were part of the LGBTQ population, and I can't what I remember from her research of the literature, it appeared that police officers typically go and typically arrest the male involved in a heterosexual relationship. That's kind of like the baseline. When they encounter a gay couple, they kind of like, they arrest both, regardless of what happens. And in a lesbian couple, they're kind of like at a loss. So it might be interesting to see how the police responds to these situations, and maybe they can do something a little bit different. Okay. I'm trying to think. There's so many things there. Oh, one thing that it has reminds me about more sociological variables here are there are sociologists who are studying sexual aggression and aggression in general, and sexual aggression, and it's kind of like a whole different pool from what we do, and it seems that there's little communication between both fields. There is an institute that has a website called malesupremacism.org that looks a lot about that aggression, and there's some researchers there who look at sexual aggression towards LGBTQ individuals and within the LGBTQ community. But that is a very, very great resource, that institute. They're kind of like seeing a merging of male supremacism and white supremacism. So that's yet another thing to worry about. What do you see as treatment implications for your findings? Our audience are primarily, they're ATSA members, they're primarily clinicians, and they may be listening to this on their way to work for some strange reason, but that's fine. I don't judge. What would you tell clinicians? What would be some takeaways?
I think kind of one of the most important things is to just ask the question. I know when I was starting my clinical work, I was so nervous to ask really any question that could potentially maybe offend the client or make the client uncomfortable. But now, the further along I get within my own clinical work and my research, I find that a lot of people just want the space to talk about it. They might not want any resources. They might not want to do anything at that moment, which is totally fine. But just starting the conversation, building the rapport, and just kind of creating that relationship, I think, is really important, because there is some data to suggest the more conversations you have with someone within a professional setting, the more likely they are eventually to take you up on your resources and maybe develop a safety plan for leaving. People aren't super, trusting right off the bat to providers, which I understand. And so I think just having the conversation and screening more is really important. So I know I try within my clinical work, within my intake, just to ask everyone, male, female, LGBTQ. If you're coming into my office, I want to ask you if you've experienced this. And again, I think that it gets the conversation moving, and it's nice to just build that relationship in that way. And kind of like I mentioned before, I think it's really important to know the full system of what's going on. So like we have the individual level factors, and now we kind of have a better understanding of the community. And so if I really wanted to, Jill and I could go into my data and we could find the counties that are potentially at highest risk based on what we have with these risk factors. So, maybe it's not so much that we need to just throw resources and interventions to everyone. It would be kind of nice if we had, certain areas that are maybe at the highest risk, and we can give those areas interventions, which sounds more cost effective in my opinion. So I think that's helpful for clinicians as well to maybe know some of these community level variables. So when they have someone come in, maybe they hit some of these risk factors, maybe this is something that needs to be discussed. One other important thing that we found in the paper had a lot to do with relationship type, and this is something Jill and I have examined kind of since I've started my doctoral studies, and so typically IPV, you think of intimate partner violence happening between dating individuals or married individuals. And from our research and other research, we know that is actually not the case at all. Some research shows that the majority of sexual violence occurs amongst acquaintances. And I think really it might be happening the same across the board, but I think a big issue here is barriers to reporting. So we know sexual violence may be more likely in spousal relationships. There's a higher level of intimacy. You've been together longer. Violence progresses with time, and they're less likely to report. Some of those include, fear of that violent reprisal, financial concerns, maybe they have children, some of the cultural considerations we were just talking about. It is not easy to leave a situation by any means. And so we do know also that acquaintances are more likely to report because maybe they have less invested within the relationship, maybe there are fewer consequences of reporting. And so I think clinicians, I think we have not necessarily a responsibility, but something to help with reporting. And, that's something I could talk about a lot, but there's a lot of different ways to anonymously report online. Instead of getting police out there, I recommend we kind of have more mental health advocates, because it's true that just reporting it to the police does not always lead to a good outcome, and sometimes it leads to a bad outcome. So I think there's different, anonymous reportings online that we could promote. When you do some of this anonymous reporting, basically what happens is you get an advocate that can provide you with resources, that will talk to you, ask you if you do want to report to the police, help you with getting a protective order, some of these really important pieces that lead up to potentially eventual termination if that's what the client wants. So I think all of these things are just important to think about when we're working with every client that comes in.
What about on the side of the perpetrators? What will be some treatment implications here?
I'm going to defer to Jill on that one because that is her bread and butter. That is literally her bread and butter.
So you set me up like I'm going to have a really good answer, I see. Well, I think understanding community level influences, it would be really important to integrate into treatment of the perpetrators of violence as well. I think we focus a lot on those individual risk factors. And I mean, my own work, I focus a lot on self-regulation at the individual level. But if we're looking at things like, problematic attitudes toward women, or, facing sort of gender-based expectations of men who live in really impoverished areas that may lack resources, and what messages are they getting from society as we, talk about male supremacy, or, the ugly combination of white male supremacy, right? Like what sorts of messages are they internalizing and then acting on? How are we socializing men within society and culture, or even subcultures within, maybe the Southern US, which is where Tennessee is located, about their role in a relationship and a woman's role in a relationship, and how to handle stress and anger and frustration. Have they been socialized to be angry and violent, and how much is that just part of what they think being male is? And we talk about that to some extent in treatment, I think, but we spend a lot more time talking about individual level coping skills and that sort of thing, where maybe we need to acknowledge more that there are things going on in their worlds that it's harder for them to see that as problematic, right? Especially if we're telling them you are the problem, not everyone who taught you to be this way is also part of the problem. And I don't think we integrate that nearly enough into our approaches to dealing with, treatment related to sexual violence.
Yeah, I faced a lot of that when I was doing treatment, with Latin American men who would just start on the, well, in my country, this is not a crime. And it's like, well, that's great. I'm not going to hold you responsible for your entire culture here. But now that you know that it's not okay, what are you going to do about it? Kind of a thing. And I lost my train of thought. Okay, so the message for clinicians are more ask more questions, get to know more of the context that your clients have been living in, and I mean, there's an interplay between the societal factors and the individual factors. You know, not everybody engages in this behavior. They have better self-regulation, or they have other outlets. And this is everywhere, like in the world, except in those few matriarchal societies where there's no aggression towards women because the women are in charge, and things are much better in a number of ways. So what about prevention? Let's go back to the $1 million grant and let's make it $100 million grant. What would be some prevention? What can we do in order to prevent this? If you had $100 million and full cooperation from all governments involved.
Yes, well, I think one of the main things I would do is start with, you know, a lot of the recommendations by every intimate partner violence organization, basically around the world, the CDC, the WHO, starting education very early, you know, primary, secondary schooling. You know, I think a lot of the times we take for granted how we were raised and, you know, the kind of relationships we see when we grow up. And for a lot of folks, they don't have, you know, the blessing of seeing a healthy partnership, or maybe if they didn't have two parents that were living together, just a healthy relationship with one parent. And that leads to a lot of potentially deleterious effects, in which if we don't see healthy partnerships growing up, we don't know what kind of partnership we deserve and what we want. So having these programs, these early, you know, education programs, teaches kids maybe what they're not seeing at home. You know, also I would love to see, you know, just more communication, just more openness to talking about what does a healthy sexual relationship look like? What does a healthy intimate relationship look like? What does a healthy friendship look like? Then maybe an acquaintance relationship in which you are going to have sex. Something like that, just more open communication. And then also, what do you do if you find yourself in this situation? I think IPV still has a very large stigma around it, about being very shameful. And I think, you know, I don't know how to fix that, but I think by discussing it more, we reduce a lot of the stigma, especially in early education. And then also kind of, what do you do? So who do you talk to? Who do you report it to? And how to kind of fix the situation before it becomes a very full-blown intimate partner violence relationship, where we're having to develop a safety plan, where we have women going to the emergency room every 6 months for, you know, brain contusions, those kind of things, so we can prevent it from that. Another thing too, we've already discussed this a lot, and I'm not sure if this is necessarily prevention. It's kind of early intervention and maybe prevention of additional violence, as there's just so many barriers to reporting for women and partners out there. So like I mentioned, that anonymous reporting. I also think something that would be really helpful is nationwide screening within primary care. While not everyone has health insurance, a lot of people do go see their PCP, or if they get pregnant, they go see their gynecologist. So this is kind of like a first line access or first line prevention for a lot of the people that maybe otherwise we're not seeing. So I think the American Medical Association recommends we screen within all of these primary care clinics, but it doesn't happen. It doesn't always happen. So I think just asking the question, knowing what community resources are available, and just making that kind of consistent across clinics would, again, maybe get some of this underreporting up if individuals are interested in reporting it. And yeah, and then I think also at the nationwide level, Tennessee is kind of interesting regarding firearms, in which Tennessee does mandate that if you are a intimate partner violence perpetrator, you do have to kind of surrender your firearm. But Tennessee is kind of one of those interesting states where it doesn't have a specific relinquishment law. So the judge basically orders you to give up your firearm, but then no one really checks to see if you've given it up. Whereas other states, they kind of have that follow-through process. So here, I think that could definitely be an improvement, because we do also know that if a domestic violence perpetrator has a firearm and they've engaged in, some type of abuse, and if they've maybe used the firearm within the abuse, they're much more likely to do it again. So I think this could also be a form of prevention as well.
Yeah.
I also think some of it too is related to how we educate people about intimate partner violence. As Rachel was alluding, having earlier conversations about healthy versus unhealthy relationships, but also I think the way that people are typically educated may be misleading in some way. Well-intended, obviously, but misleading. We noticed in this and some of the other work we've done with this data set or this sample, a lot of the education about intimate partner violence starts in college, and we're seeing a pretty substantial number of people who are victimized when they're teenagers, living at home with their parents, in dating relationships in high school, and they haven't had this conversation yet, and so by the time they get to the conversation, they've already experienced this. And then the other issue is, I notice when I teach about intimate partner violence in my forensic psychology courses, people have this very stereotypical view of what this is like. They hear domestic violence and they tend to think of a fairly psychopathic, predatory man who engages in a series of sequential relationships with women where there's this very clear cycle and pattern, and he's a predator, right? And they don't think of it as what we often see when we look at the actual data, is that this is not a relationship where there's like a clear evil and a clear victim. We have reciprocal violence. We have people who commit violence against a partner that they love, right? They're not just using them and trying to hurt them. They just have really poor behavioral controls and poor self-regulation and anger issues or drug and alcohol problems or what have you. And so just also based on clinical work, not just working with students to teach them these concepts, but clients have a hard time conceptualizing themselves as being in a violent relationship because they say, oh no, my partner's not like that. Yeah. And they're thinking again of that really psychopathic, predatory, perception of what family violence looks like. And yeah. So I think in some ways, even our efforts to educate have shown them a slice of that population, but not the broader issue. And so people may not even see that they're in an abusive relationship in the same way that they would expect from what they've been taught.
Yeah. Well, the idea that, he feels bad and he apologizes. It's, yeah. I think that this is where if I had $100 million, a good communication campaign nationwide and geared towards everybody, kind of like what the New Zealand government does in regards to porn and online grooming. They have some really great commercials. Yeah, and I was thinking as Rachel was talking about the PCPs, pediatricians should be asking these questions too of teenagers. I have a daughter in middle school, and I haven't heard of aggressive situations, but there are kids who are not permitted to talk to another kid. Because of what happened when they were dating. Who knows what happened, but this is starting very, very early on. Well, actually, we have come to the end of our podcast, and I cannot thank you enough for being willing to come in and chat with me. and with all of us in the whoever's out there watching this. So thank you very much.
Thank you for having us.
Thank you.
Thank you for watching. Don't forget to visit us at atsa.com. And I am your host, Alejandro Leguízamo. Until next time, thank you.